हाँ बताइए आकाश, शुरू करिए केस।
Sir. Good evening, sir. I am presenting a case of a 54-year-old gentleman, resident of Mathura, graduate, accountant by occupation. He is a known case of chronic kidney disease with hypertension for the past 3 years. Informant being himself, now presented with complaints of loose stool since 15 days, fever for 10 days. History of presenting illness. History is dated back.
You have some slides also?
Sorry, sir.
Do you have some slides?
No, sir.
You are just speaking. Okay.
History of presenting illness. History is dated back 3 years back in 2019 when he developed headache, which was moderate to severe in intensity, pulsatile, more on the occipital region, not associated with nausea, vomiting, loss of consciousness, and abnormal movement of the body, for which he visited to local physician and found to have blood pressure of 200 by 110 millimeter of mercury. He was managed with oral antihypertensive named tablet metoprolol 20 mg, 25 mg once a day, tablet amlodipine 10 mg BD, and tablet prazopressine 5 mg twice a day. He was investigated. Baseline investigation was done, and which revealed serum creatinine of 3.3 milligram per dl. Then he was consulted with nephrologist, and he was told that he have bilateral enlarged kidney with multiple cysts. After and advised to take plenty of fluids. After managed with the fluid and antihypertensive, his serum creatinine came down to 2.1 from 3.2, 3.3 after 1 month. After that, he had episode of loose stool, 3 to 4 episode per day, which was associated with blood, which was resolved after 3 days of antibiotic.
आकाश एक मिनट यहाँ रुकते हैं। जो आपका प्रेजेंटेशन है, पहले तो the person has presented with high grade with headache and high blood pressure and high creatinine. तो आपने तो वैसे सिस्ट बता दिए हैं, तो आपको लगता है सिस्टिक डिजीज है, बट लेट अस डिस्कस दैट फैक्ट दैट ही हैज प्रेजेंटेड विद हाइपरटेंशन व्हिच इज सिग्निफिकेंट, है ना। देयर इज अ वेरी हाई हाइपरटेंशन and he has presented with kidney dysfunction. So what could be the possibilities if you just keep aside the cystic disease, which will come to later? So what do you feel about this presentation?
Sir, this is okay. As he presented with significant hypertension, this may be a case of chronic kidney disease which was not detected, or maybe a case of rapidly progressive renal failure, sir.
So one thing to discuss is that he has a significant hypertension on presentation. So it is not likely to be a primary hypertension, है ना? ये तो it can be a secondary hypertension, or renovascular or renal parenchymal or endocrinal. These are the secondary hypertension. Now, in this patient, because he has a high creatinine also, so it is probably renovascular or renal parenchymal hypertension. So what history you have taken at this juncture to find out, one, what could be the cause of hypertension, two, whether it is a chronic kidney disease, acute kidney disease, or rapidly progressive disease. You must have, and also to see the etiology of disease. This is the time when you have to ask the history for the etiology of disease also, and that you will get only from. But now because you have commented on the cyst, so we'll narrow down to one pathway only. But in that also, there will be some acute problems which will raise the creatinine, because creatinine is quite high, and you said it came down after giving fluid. Generally, fluid is avoided in a patient coming with hypertension and renal failure. So you have to describe in detail what are the circumstances in which he has presented. So I could not catch from your history that. Okay.
So I will ask for history of hematuria.
You've already asked. You tell that. You have to narrow down the diagnosis. You've already asked the history. So you say at that time patient was having adequate urine output. And you have not mentioned that. Hematuria you have not mentioned. History of nocturia, edema. Okay, history of. So you have to find out the cause of that kidney dysfunction at that juncture only with the help of history.
So he did not complain of any visual disturbances, hematuria, pain, abdomen, palpitation, burning micturition, renal stone, lithuria, nocturia, blood in vomiting, jaundice, and abdominal distension. There is no history of bone pain, fracture, easy fatigability, fever, or reduced urine output. His urine output was adequate and good. And there is no history of over-the-counter drug intake and no history of blood transfusion in the past.
So now with incorporation of this history, do you feel this episode of kidney dysfunction, is it an acute episode? Is it a chronic kidney disease? Or is it, some rapidly progressive disease? What is the type of this renal dysfunction episode which has occurred?
Sir, it may be presented as rapidly progressive renal failure, or it may be presented as acute on chronic kidney disease.
Why do you say rapid and why do you say acute on chronic? Let us discuss that. Why do you say it as an acute renal failure?
Ankit, you have to understand this is an old man of 57. He is presenting for the first time with hypertension. There is no other relevant things you have mentioned, except on evaluation, you said his creatinine was 3.3. So Professor Ravi is asking you, what is your thought process now? Person is presenting with what grade of hypertension it is?
So it's stage 3, grade 2, grade 3, sir.
Which classification you are mentioning?
Sir, AHA, American Heart, sir, JNC classification, sir, stage 3.
This is the JNC classification.
According to American Heart classification, this is.
Don't confuse. What is JNC? What is JNC classification you mentioned?
Sir, blood pressure of more than.
What is full form of JNC?
Joint National. Sorry, sir, I'm not.
This is the Joint National Commission of Detection, Evaluation, and Treatment of Hypertension. This is a body which has been giving reports every 4 years. Based on 32 sub-bodies. We have got American Diabetic Association, Heart Association, Dental Association, Nursing Association. All these 32 bodies pool the data, and then after every 4 years, this was coming. And after 8, there's no JNC coming. All right. So Dr. Ravi asked you that this is let us say, a class 2 hypertension. This person has presented, he is 53 years. What can be the possibility? His creatinine is 3.3 and he is presenting with hypertension and headache.
Sir, this may be a case of as he presented with deranged renal function and hypertension. Sir, this may be a presentation of rapidly progressive renal failure, sir.
Why are you bringing rapidly progressive renal failure?
Sir, because
he has come for the first time to you. You have incidentally found out that the hypertension is 3.3. Why are you bringing rapidly progressive? Rapidly progressive, you bring out if you know the background. If you had known that his creatinine has been normal 10 days back, 15 days back, you could have brought rapidly progressive. Why are you mentioning the term rapidly progressive? That is what Dr. Ravi pointed out. He is just presenting. Don't get bogged down because you know the case. You are presenting a case as a layman. As first time patient has entered your OPD, he comes with high blood pressure. You record, you see his creatinine is 3.3. You will straight away jump to rapidly progressive renal failure. What will be your thought process?
Sir, this may be because of high blood pressure. This may be a cause of deranged renal function, sir. High blood pressure that lead to hypertensive renal disease, sir. Or sclerosis because of high blood pressure.
So are you talking now that he has got chronic kidney disease? What you are talking of benign nephrosclerosis, you are talking of a chronic kidney disease now. So now your diagnosis is shifting to chronic kidney disease. Is it CKD? Or Dr. Ravi asked you, it is AKI. Can malignant hypertension, which used to be or severe hypertension, can it result in AKI?
Yes, sir. It can present.
What is it called? How it will result?
Sir, malignant hypertension can present as AKI.
How does it damage the vessels? What does it cause? What is the mechanism?
The fibrinoid necrosis that can lead.
It can give rise to that. So this patient presented to you with hypertension. The creatinine was 3.3. And now you found that he has got enlarged kidneys. All right. Now you proceed ahead. You did an ultrasound. You found, what did you find in ultrasound?
The bilateral enlarged kidney, sir.
That's all. That is the ultrasound report.
Sir, this is according to the patient, sir.
Okay. Go ahead.
He was lost to follow up, but according to him, he's taking antihypertensive medication and now presented with complaint of loose stool from 15 days, which was watery, 3 to 4 episodes per day, sometime associated with mucus and abdominal.
Yeah, Akash, ये lost to follow up तो मतलब कितने दिन के लिए lost to follow up है? That episode was 3 years back.
Yes, sir.
And this is now last 15 days. So we don't have any history between for 2.5 years.
No, sir. No, sir.
Okay.
But he is taking antihypertensive drug continuously, sir.
Okay.
Which was I would like to mention one point.
ना आवाज कम आता है ना इस फोन में.
Sir, there is a history of one episode of sir, am I audible, sir?
You are audible.
Yes.
Sir, now presented with loose stool from 15 days, watery 3 to 4 episodes per day, sometime associated with mucus and abdominal fullness. Mild diffuse abdominal pain was associated, and this loose stool was partially relieved by taking oral antibiotic and other supportive treatment. And this episode, it is not associated with blood in stool and vomiting. And he also complaining of fever from 10 days, which was high grade, associated with chill and relieved by taking NaSID. So for this, he got investigated himself and found to have serum creatinine of 6.4 milligram per DL. During this presentation, there is no complaint of burning micturition, urgency, or frequency of urination and hematuria. No complaint of flank pain, yellowish discoloration, and no complaint of bleeding from any side, and no blood transfusion.
आपने बहुत इंपॉर्टेंट हिस्ट्रीज इसमें छोड़ दी हैं. अभी तो पिछले एपिसोड का भी एक्चुअली क्लियर नहीं है, बट इस एपिसोड में एक डायरिया के साथ पेशेंट हैज रीनल डिस्फंक्शन. So what is the first history you ask? The amount of diarrhea, how profuse, and how many times he passed motion in one day, whether it was 20 times, 10 times, whether he was able to replenish the water.
Sir,
have you asked that?
Yes, sir. This is 3. Sir, I have mentioned that 3 to 4 times per day, sir.
And did he develop hypotension because of it? Was he feeling dizzy?
No, sir. During these episodes, he did not feel.
Did he have high fever? If you are calling it a dysentery, infective diarrhea, did he have high fever?
Sir, high fever, but not associated with blood this time.
Now you have said creatinine is high.
Yes.
I am not sure whether last 2 years the creatinine was same or was it increasing. So you have to comment on symptoms which could indicate a chronic kidney disease during this time and the level of BP control. So your history should be like, knitting a sweater. everything goes in line and you get to a diagnosis. So you have missed a lot of things in between. So what is your take on that? You have come to now present history, but in last 3 years, was he having a good blood pressure control? Was he showing any signs of chronic kidney disease? Did you ask?
Sir, I have asked, sir, I mentioned in negative history, sir. Negative history, sir.
Okay.
Sir, there is no complaint of any easy fatigability for to rule out anemia, though no history of bone pain fracture to rule out CKD, MBD. Sir, and sir, urine output is adequate, sir. And no history of over-the-counter drug to rule out any acute cause of renal dysfunction, sir, which is super chronic kidney disease.
So then what happened with the diarrhea episode? Then what happened after that?
After that, so he's admitted with these complaints: loses fever and rising creatinine levels.
Okay.
You also mentioned in between that he was having fever for last 10 days with chills and rigors.
Sir.
What was the evaluation for that fever? Because first of all, don't mind, it's a very sloppy history, disappointing. I wish you should have put the slides, which everybody can see. I don't know if the trend has changed now. You are talking verbal. Is it time saving or what? Because one is not able to comprehend fully. You are addressing over 60 people. They are not able to comprehend. Can you summarize the history? Then we proceed. Just summarize the history in whatever lines you want.
A 54-year-old male diagnosed as chronic kidney disease. Basic disease was ADPKD. Baseline creatinine was 2.1. Hypertension. Serum creatinine at the time of diagnosis was 3.3. After 1 month of treatment, serum creatinine came down to 2.1 milligram per DL. He's he took three antihypertensive for the blood pressure management and well controlled according to the patient. His urine output is adequate, and now now presented with he had one episode of loose stool which was associated with blood resolved after 3 days of oral antihypertensive 3 years back, and now presented with fever, loose stools, and rising serum creatinine levels.
So what do you analyze about this fever? Anyway, you have muzzled the history, and now you are trying to say that he is a patient who was diagnosed to have CKD 3 years back. Now, over 3 years, he has progressed. The course is punctured by an episode of acute enteritis in between. And now also he had acute enteritis, which lasted for 3 days. And he also has fever for 10 days, you are saying. What is the analysis of this fever with chills and rigors?
Sir, I have taken history. Sir, he to rule out UTI, as he said that he did not have burning micturition, urgency, or other urinary symptoms. He did not complain of any flank pain or any bleeding from any sides or any cough, cold, sir.
What is your analysis?
Sir,
you have made a diagnosis of CKD. Probably you are saying it is a case of ADPKD, who has presented now with 10 days history of fever with chills and rigors.
And sir, loose stools, sir, this is the
But
case.
you said loose stools have stopped.
No, sir. Sir, this is the episode 3 years back. He had an episode of loose stool 3 years back.
Now the loose stools are still continuing?
Yes, sir. Yes, sir. 3 to 4 times per day, sir.
Loose stools are they also there? And
yes,
he has got fever also.
Yes, sir.
Okay. So what is your analysis for that?
Sir, this may be fever is because of acute enteritis or acute decompensation of creatinine is because of sepsis, and sir, volume depletion, sir.
So you are saying this episode is a acute on chronic, where the patient has a dehydration or infective pathology. Let us say he did not have fever and diarrhea at this time. Now patient had 2.5 creatinine few years back. Now he has 6. So is it like the course of a ADPKD?
No, sir. This is not the typical course of ADPKD, sir.
Why do you say so?
Sir, the GFR decline in ADPKD is 5.5 to 5.5 ml per minute per 1.73 meters square per year, sir.
5.5 तो इसमें कितना चेंज हुआ? 2.5 था क्रेटिनिन तो 20 ml के 25 ml होगा और 2-3 साल में अब 15-12 ml के करीब आ गया.
Sir, this is sir, but patient is
not. Did you get this figure of 5.5 and this thing? The polycystic kidney disease is the slowest progressing disease. First thing to highlight is it is the slowest progressing. It doesn't progress that fast. Now, because you have said that, second question is that what are the factors which cause rapid progression of polycystic kidney disease?
Sir, uncontrolled. Sir, this may be of. I started with environmental factor. Sir, caffeine.
Yeah. Classification. You tell the factor. You tell it.
Sir, early age of CKD. Sir, early age of diagnosis of ADPKD.
So he was 54.
Sir,
तो early तो था नहीं. फिर
Sir, this is because of a sepsis component, sir. This is
वो ठीक है, पर अगर मैं कहता हूँ कि पॉलीसिस्टिक किडनी से क्रॉनिक ही हो गया, अब ये तो he will not recover. Sepsis तो चलो secondary है, maybe already he had a creatinine of 6. So we are searching for pointers to have rapid progression. So one you said is early onset. Second,
any urological procedure before age of 35, early age of diagnosis of hypertension before age of 35, sir.
So clinical manifestations of ADPKD occurring in early age. That is one point. Whether it is hematuria, hypertension, UTI, stone, whatever. Then what else?
Sir, this may be because of the mutation, PKD2 mutation and truncated mutation is most likely to progress. ADPKD more likely to progress than non-truncated or PKD2 sir gene.
नहीं, PKD2 तो slow होता है यार, PKD1 fast होता है.
Sir, PKD1 and non-truncated mutation rapidly progress.
तो type of mutations एक हो गया और
sir, environmental factor like caffeine intake or sir high protein intake and sir biochemical factor like increased urinary sodium or sir
size of the kidney है ना, rapidly enlarging होगा.
Total kidney volume.
Total kidney volume is the most important है ना, and control of blood pressure, that is the most important है ना.
Yes sir.
तो यही सारे factors इसमें आपको assess करने हैं तो rapid progression के लिए.
Doctor साहब, कब से patient is admitted with you for how many days now?
Sir, he is admitted from sir 2 days, sir.
Only for last 2 days.
Yes, sir.
What has been your evaluation, investigation so far? Before we come to discussion, you finish your case.
सर एक बाकी फैमिली हिस्ट्री और वो आपने लिया है, तो आप हिस्ट्री और बता दो सारा पहले.
So past history, there is no history of diabetes, coronary artery disease, tuberculosis, CVA or COVID-19 disease in the past. Family history. Sir, his father also a case, diagnosed as the case of ADPKD at the age of 45 years. In 1992, he underwent renal transplant surgery and father was expired in 1998 because of infection, according to the patient, sir.
At the age of 45, his father was diagnosed ADPKD. When was he put on dialysis? At what age?
Sir, he did not. Sir,
you said transplant?
Yes, sir. Transplant, sir. 1990.
You mean he received preemptive transplant?
Yes, sir.
Which,
नहीं, age of person at time of transplant, वो तो आप बताओ ना.
what was the
At-
age?
हाँ.
Age at time of transplant.
Sir, 68, sir. 68 in 1992 में sir transplant हुआ था.
No, at the age of 68,
Yes, sir.
and he died at what age?
After 7 years, sir. 74, sir.
At the age of 74. So that means he was diagnosed at the age of 45. So he went on dialysis.
Sorry, sir.
Roughly, I mean, he went into end-stage kidney failure, roughly around 65 to 67 years.
Sir, I want to correct my statement, sir. Sir, he diagnosed, first he diagnosed ADPKD at the age of 45. And sir, he underwent renal transplant surgery at the age of, sir, at the age of 50 years. And after 6 years of surgery, he expired because of infection.
So he got transplant at the age of 50 years. That means that is the time he went into end-stage kidney failure. That is the father. Any other relevant history?
Sir, his son, who is 24-year-old, is also diagnosed as. He's told that he also had a renal cyst. He evaluated during 2 years back because of renal stone, sir.
His son also has got kidney cysts.
Yes, sir.
And the son also has got kidney stone.
Yes, sir.
All right. Any other relevant history? Then we will come gradually to discussion.
Sir, drug history, sir.
You have mentioned important history.
Sir, he's chronic smoker for 15 years. He smoked 2 to 3 cigarettes per day, but he stopped smoking from 6 months, sir.
All right. He has been chronic smoker. What else?
Sir, please.
In hospital now, he's admitted with you. Can you give us the investigations in the last 48 hours?
Sir, there is, sir, in CVC,
Investigations.
yeah. Sir, in CVC, there is leukocytosis. His count is total leukocyte count is 18,000, and hemoglobin was 11.1, and platelet was 127,000, sir. His creatinine is 6.5. Electrolyte was within normal limits, sir. Sir, his blood culture was sent, which the report is awaited. And sir, urine RM, sir. Sir, urine RM, sir. There is no pustules or RBC in the urine, and protein is trace, sir. Okay. And sir, USG suggestive USG ultrasound was done with suggestive of query diverticulosis, sir. Diverticulitis, sir.
So ultrasound, what was done?
Sir, whole abdomen was done.
So that is suggestive of
diverticulitis, sir. Query diverticulitis, and we plan for CT scan.
You plan for CT. Okay. What antibiotics you are giving him?
So we started injection Metrogyl and ceftriaxone.
Okay. All right. Any other investigation, Ravi, you would like to ask? Then we start with him now. Because now with the bits and pieces, you have collected the data that this patient with a strong family history, his father had ADPKD, he received transplant. The individual son of the age of 25 also has been picked up to have ADPKD. And this patient has been picked up ADPKD 3 years back. Anyway, he has now presented with acute enteritis, pain abdomen, and fever. The working diagnosis you are thinking Could it be acute enteritis? That is one. Possibly diverticulosis you feel. And second, any other possibility? Could it be a cyst infection?
Sir, cyst infection is less likely, sir, because he presented with GI symptoms, sir. So, sir, this I will keep it, sir.
So the first possibility you have kept it, that he has got acute enteritis, and diverticulosis could be one of the possibilities of that. Number two.
Sir, it may be because of cyst infection that lead to a fever, or sir, there is no obvious symptoms or investigation which suggestive of urinary tract infection, sir. And sir, sir, on example,
keep in mind, just please don't confuse. Number one, two, three clarifications I will like to give you. Number one, whenever you talk of cyst infection, majority of the time urine is normal.
sir.
There is no UTI. UTI is a different entity, cyst infection is a different entity. Some of the cysts are communicating, but majority at this point of time are non-communicating. So cyst infection will not cause urinary positive findings. That is, lower UTI is different, cyst infection is different. Secondly, you were harping multiple times on the caffeine. Lot of data is available now that caffeine drinking is not harmful. There's a French data, there are other studies which are coming, which are showing clearly that coffee drinking is not harming ADPKD. All right, so that also you keep in mind. Now we come to you one by one. His son has been diagnosed with ADPKD at the age of 25. What is criteria? What criteria you will use to label him as ADPKD at the age of 25?
With positivity of ADPKD, so there is Revine criteria, sir. Revine criteria.
What was the criteria?
Sir, age less than 30, less than 40, two cysts in either of the kidney, 40 to 59, 3 cysts in each kidney, and more than 60, it is more than 4 cysts in each kidney, sir.
Are you sure about the criteria? That is all right. Above 60, you said
3, 2, and 4.
All right. Anyway, so that means you are going to pick up to the child has got, he's just 25 years.
Sir.
All right. Second, you said in this child, he had stone. That is how he was picked up. What type of stones are there in ADPKD?
Sir, uric acid stone and calcium stone, sir.
Are uric acid stone radiolucent or radiopaque?
Sir, these are lucent, sir. In your
so how was the stone picked up?
Sir, CT scan, sir. CT.
Was it done? I mean, I'm just asking you. Anyway, you should be aware that these are uric acid stone predominantly and could be calcium oxalate also. Now, you come to Ravi, first you asked any question.
So now as sir is discussing about the child. So the child has cysts and stones. So how would, we are clear now that it is a ADPKD. And so there is one question which is that what are the cystic disease of the kidney? And we should actually start with that. So what are the, can you spell out all the cystic disease of the kidney? Can you tell me?
So cystic disease can be classified as genetic cystic kidney disease and non-genetic cystic disease. In genetic cystic disease, it may be this is 3 types, 3 pattern of inheritance. In this the autosomal dominant polycystic kidney disease, von Hippel-Lindau syndrome, and tuberous sclerosis. And second is autosomal recessive In this category, autosomal recessive polycystic kidney disease, and sir, nephronophthisis, sir. And third is X-linked disease. There is a orofaciodigital syndrome type 2. And sir, non-genetic disease, there is developmental cystic kidney disease and acquired cystic kidney disease, sir. In developmental cystic kidney disease, there is two disease, medullary sponge kidney, and second is medullary sponge kidney and multicystic kidney dysplasia. Third, acquired kidney disease in the simple cyst, unilateral multilocular cyst, cyst because of hypokalemia, and acquired cystic kidney disease.
So the point to ask of this was that when you are evaluating a case of cystic disease, so you should give importance to the presentation, whether which one of these cysts is there, because this person has a strong family history and the kidneys are enlarged and there's different, so you are sure that it is ADPKD. But otherwise, in your presentation, you should actually comment on that. So as you said, in autosomal dominant, there are 2-3 diseases. How do you differentiate, like where von Hippel-Lindau है या आपका tuberous sclerosis है, कैसे present करते हैं वो लोग?
Sir, these disease, von Hippel-Lindau syndrome is presented with hypercalcemia, because in this primary hyperparathyroidism, sir, is there. And sir, tuberous sclerosis, there is multiple skin lesion, caveolate, sagrine patch, and mainly of angiofibromas and sir, tuberal and brain involvement in form of
okay, so you should ask in patient about these things, because only by history you will get some idea whether there is a secondary systemic involvements. So you have to take history of systemic involvements. That is very important. So in ADPKD, what are the systemic involvements?
Sir, most common cyst involvement, sir, liver is the most common organ which involved in ADPKD. That is increased with age, but eventually it is around 80% of cases who have got had autosomal dominant.
So one, you are saying that there are cysts in other organs, and yes, like cyst in liver, kidney, liver, spleen, pancreas can also have. So yes, this is. Then what other involvements? One is cyst in other organs, and sir, what is the other involvements? You have asked in your patient or not these things?
Yes, sir.
You have to ask in your patient the other systemic involvements. Sure. So what are the other systemic involvement?
So other systemic involvement can be intra-aortic aneurysm or coronary artery aneurysm and cervicovertebral artery aneurysm, cardiac involvement in form of mitral valve prolapse, cardiomyopathy. It may be presented with atrial fibrillation, and sir, and coronary, sir, in lung involvement, bronchiectasis, which is 3 times commoner than general population. Then, sir, in the abdomen, cyst in pancreas, liver, and sir, diverticulosis.
Diverticulosis association is there, and CNS aneurysms.
CNS aneurysm, sir.
So did you ask all these things in your patient? Is there any involvements? And you always, while taking history, try to find out. Okay, so one question was that how to differentiate different cystic disorders. Another is to see the systemic involvements. That is how you differentiate also. And about ADPKD also, you have to see which systems are involved. Sir, so any question from your side, sir?
Yeah. What do you think now? Let's come to this case only. Do you think he's a type 1 ADPKD or type 2?
Sir, this is as family history is very strong, sir. This is a type 1, sir.
More likely to be type 1.
More likely to be.
More, okay. Why do you say so? Because he has got a strong family history. What else?
Sir,
Positive family history does not mean he becomes ADPKD1.
the index case is most likely a case of PKD2, but
No, you please don't confuse yourself.
sir,
I'm talking about the present case. Do you think he is ADPKD1 or he is ADPKD2?
sir, he's ADPKD, most likely ADPKD2 types. Sir.
Why do you say so too? I say he may be most likely his father got diagnosed ADPKD at the age of 45. At that time also he must be having good amount of kidney dysfunction. At 50 years, you said he received transplant. And at 57 years, he died. So he possibly had ADPKD diagnosed pretty early. End-stage kidney failure was before the age of 50 years. Right? So could be that he has got ADPKD1. But with a family history, what else? So age of onset is important. And this can ADPKD occur in neonate or infant also?
Yes, sir. This is a very early ADPKD, which can present in less than 18 months of age.
Why so?
Sir, because
what is wrong with there?
Sir, there may be association with the tubular sclerosis type 2 gene.
No, that is different. You are talking about when you talk of truncated and non-truncated mutation. The truncated, on which chromosome is the defect is in ADPKD1?
Sir, this is 16. Sir,
16. So when you say truncated mutation, it's a large mutation. And close to that also is the tubular sclerosis gene. So it can occur along with that. That is different. But it is generally a single allele which causes ADPKD. If very early, VEO, very early onset ADPKD is biallelic. So both the alleles are affected. Therefore, the child maybe in the early period might have ADPKD. All right. So this patient you feel could be, his father could be a case of ADPKD1 because the only differentiating points with you are age of onset, what happens, and early onset is generally. But also keep in mind, in Indian scenario, the disease appears little earlier than Western scenarios. All right. Now, if you do a mutational analysis of all patients of ADPKD, what percentage will be ADPKD1? What percentage will be ADPKD2?
Sir, 75% patient are ADPKD1 and around 15% rest ADPKD2, sir.
What about the others?
Sir, other genetic mutation are very rare, like GNA mutation seen in 0.3%, sir. Or DNA JV9 can and presented with
that. You are right. You have to keep in mind there are more than 1,000 mutations. I'm talking about the old data of 2012-13. By that time, more than 1,000 mutations were known. So you are right, almost 80% or 75% are type 1, 10 to 15% type 2. And still, if you do genetic analysis, 6 to 8% patients will not fall into either. So all these rare mutations can be there. So you have to keep in mind that if you are doing a genetic analysis, it is not mandatory that everybody will fall into ADPKD1 or 2. There can be multiple different things. So now you know about biallelic also and different mutations. Now, this patient, is he a rapid progressor or he is a slow progressor?
Sir, he's...
what was the kidney size in ultrasound?
The kidney size is, sir, 13 centimeters, sir.
13 centimeters. So is he a rapid progressor or a slow progressor?
Sir, he's slow progressor, sir.
Why do you say so?
Sir, because sir, age first.
Dr. Ravi is not happy with your answer. He says why it is slow progressor. Now, you said 3 years back, his creatinine was 2.1. What is the GFR? You calculate GFR?
Yes, sir. I
What was
calculate
the GFR at that time?
40, sir. 40, sir. GFR is 40.
40. What is the GFR now?
Sir, this is around sir 10.
10. So the GFR drop is there of 30% in last 3 years. Does it make it a rapid progressor or a fast, slow progressor?
Sir, this acute
Could be. I agree with you. Could be. This could be an acute insult also. Now let the acute insult be over. Maybe the creatinine settles down to 4 or 4.5. So what is a rapid progressor? You can answer that question.
Sir, rapid progressor, sir. First thing, sir, there is a few criteria. The Mayo classification, sir, and pro PKD score, sir. That will tell whether this is slow.
Which one you want to tell first?
Sir, Mayo classification, sir.
Mayo classification. Yeah, what is that? Keep in mind, Mayo College in US is a key center for ADPKD research. The project, the ADPKD project is ongoing. Even today, it is ongoing. So what is that? The classification that is also called, what is the other name? CRISP.
Sir, CRISP.
Okay, what does CRISP stand for?
Consortium of Consortium Radiological Investigation for Patient of.
Good, Shabash. Now, what did it say?
Sir, it says that they divided in 2 classes, class 1 and class 2, and class 1 is further divided into class 1A to 1E, sir, on the basis of total kidney volume, age, and height, sir.
All right. Now, what was the rate of growth in stage 1, 1A, B, C, D, E?
Sir, in stage 1, it is cyst size increase per year, annually increase in 1A is less than 1.5 and 1.5 to 1.3,
1.5 to 3, 3 to 4.5, 4.5 to 6, 6 and above, isn't it? 6%. Not, this is not the GFR, keep in mind. This is cyst volume. And which are taken as rapid progressors?
Sir, cyst and growth annually more than 3 centimeter or that is
nothing called 3 centimeter. You are saying 1C and above. 1C is more than 3 mm, 3 cc, 3% increase in cyst volume. So if you are having more than 3% increase in cyst volume, logically, you are going ahead, you are saying rapid progression, isn't it? Now, this cyst volume correlates with the GFR. If you have to correlate with GFR, roughly, it will come to a roughly, GFR will be around 60%. All right. So that will be corroborating with that. And you also know today, the first stage of progression of CKD, the ADPKD, is increase in cyst volume. And second stage is that the GFR stops dropping. Dr. Ravi mentioned to you that in ADPKD, progression is slow, isn't it? So a stage is there, mind you, the progression in ADPKD is a double-edged sword. It is very slow. It is a plateau. The GFR remains static for years. This ADPKD has not started now in this man, 54 years. ADPKD started at birth. So for years, the GFR stayed static. And then it stops falling. When it stops dropping down, it is a very rapid decline. The GFR decline is faster than other diseases, but till after a time when it starts falling. So that is the time you have to pick up that what is the speed of fall. So one criteria you said is the Mayo classification. If I don't know the background history, suppose I know the background history, how much should be the GFR decline?
So mostly GFR is stable till the age of 40 years.
So I said now decline. If
When it's decline, it is
rapid. We are talking about now rapid progressor. One criteria you said, 1 C, D, E.
Sir,
Number
if
two.
GFR decline is 2.5 ml per minute in 5 years or in 1 year, 1 year and 5 sorry sir, 2.5 ml per minute per 1.7.
So if you have got last 5-year data, the GFR should have dropped by 12.5 ml or more. That is second. Good. Third criteria.
Third criteria, sir, USG volume, kidney volume in USG more than 60 centimeter.
Not volume, kidney length.
Kidney length.
Length more than 16.5 centimeter below the age of 45.
Sure.
So that is also a criteria for rapid growth. Next.
Sir, pro-PKD score, sir. Pro-PKD score.
So now you want to come to pro-PKD score. All right. So pro-PKD score, can you calculate?
Yes, sir.
How do you calculate?
Sir, it consists of male gender, which give a 0.1.
So in this patient, you give 0.1 to the male gender. He is male?
Yes, sir.
1.
Yes, sir.
Next.
Second, sir, first urological procedure before 30, sir.
Second, you said is hypertension.
Hypertension.
Hypertension before the age of 35. Now, he did not have, we don't know about this patient. He was picked up only 3 years back at the age of 51. So we don't know.
Sir.
He may be having hypertension. We have got no idea. Third criteria, that is 2 marks. Now you come to third criteria that, as Dr. Ravi mentioned to you, that any urological complication, stone disease, or whatever, hemorrhage, or whatever infection occurring before the age of 35. To give another 2 points to that. In this case, you have not given any history of hematuria, stone, or this. So nothing. So at the moment, you have got only 1 point. Hypertension, we don't know. Next is the person having
mutation, sir.
Yeah, that is a mutation. Now, if you are trying to say it is ADPKD2, he gets 0 point. Truncated mutation, 4 points. Non-truncated mutation, 2 points. And ADPKD2, 0 points. So if you are trying to say ADPKD2 are non-truncated mutation, he is not a rapid progressor. If you go by pro-PKDs. If you go by GFR score, that even if in the last 1 year, GFR drop is more than 5 ml, he becomes rapid progressor. So you have to find out, once he settles down, once the creatinine gets stabilized, what is the GFR? Does he fall into rapid progressor or slow progressor? Isn't it? Because your treatment after that, first, your priority is treat his diverticulitis. He has got sepsis because diverticular, the abscess formation is there. And if there is a lot of abscess formation in the gut, it is difficult even to do colonoscopy. Sometimes there are different opinions that there is a fear of rupture if the disease is so bad. And if not rupture, even if you are going through, there is fever of bacteremia further. So once you are stabilized, possibly that is the time you will go for colonoscopy to confirm whether the diverticuli are there or not. Isn't it? All right. Now, how do you want to go ahead with this patient? You have treated him. He becomes all right. His creatinine, let's say, settles down. Theoretically, let's say creatinine settles down to how much, Ravi, you say 4 milligram? What is your bed?
Okay, 4.
All right, 4 milligram. What is the GFR now?
Sir, GFR.
You can calculate. He is a man of 54. GFR is Anyway, whatever, let's say it comes to whatever, 25 or something,
Sir.
20 or 25. So as per your criteria, he will become rapid progressor. From 2.1, he becomes 4. How will you like to treat him?
Sir, I would like to treat with conservative management. Then in this patient first, sir,
What conservative treatment? You tell us that.
sir, blood pressure control, sir. First thing.
Now, he was started on 3 drugs. You said metoprolol, Presopress, and amlodipine.
Sir.
Now, if you are the nephrologist, which drug you will give first?
Sir, clonidine, sir. Clonidine, sir, alpha, central acting, sir. Clonidine, sir.
You will try to give first drug. Mind you, hypertension is renin-angiotensin mediated. Because of cyst enlargement, there is a pressure on the vessels. There is increased renin production. So therefore, whatever ACE or ARBs you are giving, that should be your #1 priority of drug. Because this is a renin mediated, not clonidine.
Sorry, sir. Sorry.
You are trying to control blood pressure. So that is the first thing you want to give. Then,
sir, then beta blocker followed by calcium channel blocker, sir.
So that is, you have started giving ACE inhibitors. Now, which were the trials which show how much blood pressure you will like to keep of this person?
Sir, if
initially when he came, it was 210 by 110. It was very bad. You controlled his blood pressure, possibly stayed. What is your target?
Sir, in this GFR, I target 130 by 80, sir. If GFR,
your own guess or any study also?
Sir, HALT PKD, sir, HALT PKD trial, sir.
What does HALT PKD trial tell you?
Sir,
2 trials, HALT PKD.
A and B, HALT PKD trial A and B. A was for early ADPKD cases and with GFR of more than 60, and B for 25 to 60, sir. 25.
He will fit into that maximum. So what does the study say?
The study says that in PKD A trial, in this they divided into low blood pressure control group and high and standard blood pressure group, and one more group ACE inhibitor with ARBs or only ARBs, sir. ACE inhibitor, sir.
So the crux was what? #1.
Telmisartan and sir lisinopril was the drug, but the drug.
The crux was
blood pressure. How much blood pressure?
Sir, if GFR is in early GFR is more than sir, they recommend that blood pressure control should be 110 by 75.
Yes, that is what it is. One part is telling you that combination is not useful. ACE and ARB, only one drug is enough. Second is telling you when they compared 130 by and 110 by 70, 110 by 70 was statistically better, isn't it? So that is now conservative therapy. You said #1, you will like to control the blood pressure. For blood pressure, your first choice will be ACE or ARBs, and you will try to keep blood pressure as low 110 by 70 or as close as possible. Many times it may not be possible to bring that, but whatever lowest possible you can keep it that. That will retard the progression. #2.
Sir, salt intake, sir, should be 5 grams per day, less than 5 grams, sir. And sir, smoking cessation.
All right. So you have, that's good. He's a smoker, but you said he left 6 months back. So smoking cessation is required. That's important. Less salt intake. WHO recommends how much salt for you and me? What is the salt recommendation for general public? Indian population is taking 10.98 grams of salt per day. That is a Georgia study from India. And South Indians are taking more, logically because of summer and whatever. So the salt intake in India is around 11 grams. WHO recommends 5 grams, and people who are CKD are hypertensive, recommendation is even less. All right. So salt intake has to be reduced. Right? So their recommendation is sodium intake less than 2 grams. So that is next. Next, conservative. Dr. Ravi will take it. What other conservative you want?
Yes, what other methods you can manage this patient?
Sir, range lipid profile can be a cause of rapid progression in this. So lipid control, the lipid control, and sir, fourth is sir, tolvaptan, sir. We can give
So
tolvaptan.
we are talking about now direct intervention. So direct intervention to slow the progression.
Yes, sir.
So you have talked about tolvaptan. So how does it act and what are the studies about it?
Sir, it is a vasopressin agonist. Sir, sir, according to Tempo trial, it decreased the progression of total kidney volume, but the effect on GFR is less significant.
Which are the trial? Which trial you said?
Sir, Tempo
3:4 and Tempo 4:4. Two trials are there. So what do they say?
Sir, Tempo, this is a multicentric double-blind trial. Sir, in this this trial for 4 month follow-up and for last for 3 years. 3 years, sir. According to this trial, the inclusion criteria were age more than 18 years and GFR more than 60. So GFR more than 60 and patient who are rapid progressor, they describe as Mayo classification class 1C to 1E and total kidney volume more than total kidney length more than 16.5 for the age of 50, sir. So these were the conclusion criteria.
Conclusion was
kidney volume more than 750.
750.
More than 750 kidney volume. And two groups of analyzed more like age-wise up to 80 years.
Up to 80.
Okay. Then what was the dose used? That is the most important. That what was the dose of the medicine used?
Sir, they start with 30 milligram in the morning and 15 mg in the evening, sir. And after that,
so what is the strength of tablet you get in the market?
Sir, 15 mg, sir.
15 and 30 also some brand have. So now you see the dose they are using. You have to use at least 45 to start with and going up to
90 plus 30.
Yes. So very high doses.
They used 120 milligram. If you are asking about Tempo 3:4 trial, out of all the patients, for 55% use 120 milligram. Another 20-25% use 90 milligram. And another 24% to be precise use 60 milligram. So as Ravi mentioned, the dose of use was pretty high. Now, in Indian scenario, but the question will maybe is difficult. How do you titrate the dose of tolvaptan?
Sir, basically, sir, the dose of tolvaptan is titrated with the urinary osmolarity. As used in this trial, urine osmolarity, sir, less than kept should be kept between 250 to 280 milliosmol. In Indian setup, we can titrate with if in resource limited areas, urine RM, urine specific gravity. That
no, what you are saying is all right. That though they did not, there is no mention in the trial that what they tried to do with the osmolality. They there is no mention whether in Reprise or whether in Tempo trial that they aimed at osmolality. But inference is that you are trying to make the urine dilute. So like what is the poor man's tolvaptan?
For water, sir.
Water, take water and water. So that is what you are wanting to make the urine dilute. So their osmolality in large number of patients was less than 150. All right. And majority of them, it was less than 200. So what target you want to achieve, I really can't dogmatically tell you. You should do that. But I'll be happy if you are targeting the osmolality below 200. So it's a combination of lot of water. Like you said, poor man's tolvaptan is basically a lot of free water. And you have to, but the only drawback with water is that one, you have to take it 24 hours. It is not that 9 o'clock you stop, you are sleeping, 9 o'clock to 7 o'clock in the morning, there's no water. So it is per person, you will advise them to even get up in the night to take water and then sleep. All right, but that is not very practical or possible. And secondly, you can induce hyponatremia in these people. So therefore, tolvaptan has got a definite place. Tolvaptan, how much you give, don't ask me, don't quote me, but try to give as much you can give. Certainly, keeping the osmolality as low as possible, preferably, as you said, some people do comment on what you have said. I'm not trying to tell you you are wrong. Some people do try to keep it below 250, but I will prefer if you can keep below 200 because majority of the patients in these trials were below 200 osmolality. Try to keep that. All right. So if you do that, how much urine a person will be passing?
Sir, more than 3 liter if we give the...
No, person will be passing 6, 8, 9 liters. And that is how he will get fed up. If you look at the non-compliance rate in any of these trials, it is 25%. Because people will not be able to take that much. So if a person is passing 6 to 8 liters, you can imagine he has to get up after every half an hour, 1 hour. So what is the option? Is there anything which can help you?
Sir, thiazide can be
Good.
introduced.
But you can have that also, that though it is too early to say that they are extremely useful, but the recent studies are suggesting that if you are taking thiazides or even metformin, addition of metformin or thiazide, that they reduce the urine output by 25% or more without hampering the progression of CKD. So that is coming. We don't know. Gradually, this will appear. The early trials are there with thiazide, as you mentioned, but there is not large number of population. All the trials, even you have got TAME trial. Again, the trial is less than 100 people. So let's see. But keep in mind, yes, if you are asked in exam, what can you do? Yes, you have got thiazides, you have got metformin. They can be combined with tolvaptan without harming tolvaptan and benefiting the patient. The patients welcome this change. But otherwise, you can always tell a patient that whatever tolvaptan or water intake, they will have to stop in the night. Ravi, yeah, your comments. Yeah. So that is one way you can halt the progression. But suppose he does not turn out to be rapid progressor. Suppose his creatinine goes down back to 3 milligrams after you control it. So if you, by definition, he does not turn out to be rapid progressor, you will still follow all the conservative management what you mentioned. By using tolvaptan, possibly you can delay the progress, delay the end-stage kidney failure by few years. by 7 years, 6 years, depending on earlier you start, more benefit you accrue. So, but if you are not trying to give tolvaptan, if a person is not a rapid progressor, in that case, all the conservative treatment, what you said, stopping smoking, control of blood pressure, stopping extra proteins, if there's a proteinuria, checking the proteinuria, if there is whatever risk factors are there, you have to check them. Right? Dr. Ravi.
So another thing I want to mention is that after treating for 4 years, you may be able to delay 1 year of dialysis by treating this with the high doses of tolvaptan. So how feasible it is actually in practical setting, how many patients, whenever I have tried to treat the patients, they don't tolerate. I even fear giving
be
it.
honest,
You can give one tablet is they tolerate, 2 or more, they generally don't. So I don't know what is the experience with sir.
I have got, I think, more than 10 patients, around 15 patients. I'm giving that tolvaptan, but yes, I have not given more than 45 milligram to anyone. Majority are on 1 or 2 tablets. Every month, I am monitoring the urine osmolality. They come with the Lal's lab, they come with a urine osmolality report. As long as it is less than 200, I'm pretty happy. I say carry on with the 1 or 2 tablets. I have not practiced what, as you rightly mentioned, 120 milligrams. 120 milligrams means 8 tablets or 6 tablets. I have not practiced. I'm pretty happy. But I don't have any scientific data to quote. I'm happy. I'm only saying that for the last 2-3 years, I'm using it. And I'm pretty happy. The osmolality is low. I have not charted how is the progression, but that is what I am practicing.
So actually, that is the in these studies, what their editorial says. You read that the way to assess progression of kidney disease in convention, which we do in studies, is doubling of serum creatinine, reaching ESRD. These are the hard points. So it is very difficult to do these studies in these patients because of the rate of progression which they are having. So you have to develop some other ways to assess surrogate markers for progression, like the size of the kidney or the change in GFR. So it is actually difficult to study. But as in your case, you have a child also where you have diagnosed. So what is now coming up is to diagnose this disease early in childhood and maybe start treatment early, even in first, second decade of life, and giving it lifelong, so that you can actually control the process or decrease the progression further. So that question comes is, what is the role of genetic testing? So you said we can do genetic testing. So what are the roles of doing a genetic testing in this patient?
A corollary to this is, now this patient, let's say he's end-stage kidney failure. His son comes forward. You said 25 years. I don't know what he has or not, or maybe his other son comes forward. What analysis you are going to do?
So first, I would like to screen by USG, simple radiological investigation. If there is more than 10, sorry, more than 5 cysts in ultrasound before the age of 30. So this is most likely because of ADPKT itself, sir. Or if the result is equivocal, ultrasound is equivocal, we will go for MRI, sir. So in MRI, if the in age between if cyst more than 10 in the age of 16 to 44 year, the positive predictive value is 100%. If the cyst is less than 5 between the age of 16 to 44 year, the negative predictive value is 0, sir. So basically, sir,
Go ahead.
In MRI, sir, more than 10 cysts is strong suspicious, even diagnosis.
What sir is trying to tell you is that one of the use of this genetic testing is for live related kidney donation in a family member who is not symptomatic for ADPKT till now, but he is less than 30 years of age. So in that scenario, it is very helpful to distinguish whether he is going to suffer from ADPKD or not.
So what you rightly said, if you are assessing a person, suppose his daughter wants to donate, she is 29 or 28 years. You do ultrasound, you are not very sure whether they are cysts. If on MRI, there are less than 5 cysts, you are certain there is no ADPKD. Right? If there are more than 20, normally in ADPKD on MRI, there are more than 10 cysts in each kidney. But cutoff taken is 10, not 20. It is more than 20. But cutoff taken is for scientific studies 10. Now, if you find the cysts are between 5 and 20, that is the time you will go for genetic analysis. If there are more than 20, it is clear the person has got ADPKD. If they are less than 5, person doesn't have ADPKD. If there is between 5 and 20, that is a gray zone. You will like to do genetic analysis. Or you can do, somebody is very keen to check for insurance purposes or other purposes. Somebody wants to do, that is a different thing. But otherwise, for live donation, that is required, that can be done. But it is expensive proposition, not routinely recommended. If there is doubt, only then. So that is for transplantation. Yeah. And yeah. And
So
how, yeah, please, please go
please,
ahead.
sir, please carry on. So please you comment, sir.
So how do these patients generally present? 3 years back, how did we present? This is what our question will be. Like this patient presented with hypertension. The presentation can be variable. Some people may present with flank pain or heaviness in abdomen, but generally presentation can be with hematuria or with hypertension. What percentage develop hematuria?
60%, sir. 40 to 60% develop hematuria.
50% will develop hematuria at some stage of life. What about stone?
Sir, stone is 20%, sir, stone.
Around 20%. What about the malignancy in the cyst?
Sir, malignancy is same as in general population, sir.
Yeah, the cyst can become malignant, but as you rightly said, do not carry the impression that malignancy is more common in ADPKD. No, it is as common as in general population, but yes, cyst malignancy can occur if the cyst is thick-walled, etc. What is Rovsing procedure? Some old examiners might ask you, what is Rovsing procedure?
Sir, this is done for de-roofing of the cyst, sir.
Very good, very good. Previously, it used to be done that if there is a very big superficial cyst, which may be a cause of hypertension, it is pressing the adjoining cyst. So they used to do de-roofing of the cyst. Even now, sometimes the liver cyst de-roofing is practiced, kidney de-roofing is practiced, and people have documented there is regression of hypertension. And also sometimes if there is cyst infection, or if there is, like your case, it can be something very bad that even now there are 2 patients admitted in our ward hospital who have got cyst infection. Now with a cyst infection, you keep giving antibiotics unless you are giving antibiotics which are lipid soluble, which are both in the cyst, like the aminoglycosides or the chloroquine or the fluoroquinolones. They will not respond. So you have to give them these antibiotics for a prolonged period. And if they do not respond, that is the time possibly you will have to do intervention, de-roofing or removal of the infection. Any questions? Have we exceeded time? No.
So what are the indication for removal, nephrectomy of the kidney in these patients?
Yeah.
Sir, removal of kidney, the indications are first thing, blood pressure that is not controlled, recurrent infections, and sir, if patient is go for renal transplant or there is no space for graft kidney.
for blood pressure control, I don't think that is a valid indication for that. But most importantly is if there is a need for space, if there is a space, the kidneys are very large, you have to take them out sometimes to make space in the abdomen. Second is if they have a infective pathology of any sort, like cyst infection, as I said, or stones, multiple stones which are infected, repeated UTIs are there. So infections and to create space. So these are two major indications. How do you diagnose cyst infection?
Sir?
How do you diagnose cyst infection?
Sir, cyst infection, sir, sir, leukocytes, sir, PET scan, sir, PET scan.
Okay. So in CT scan, first thing is blood culture. Okay, blood culture is the most important test. Second is CT scan contrast enhancement of the cyst. If you have to do a contrast CT, plain will not tell you. Third is you can do a PET scan or gallium scan or a tagged WBC scan. Earlier we used to do that. Tagged WBC scan picked up which is the side which kidney is having infection. So I think these are the questions. Anything else, sir?
Yeah, I think, don't mind we asked you, but we certainly will like that so the student should prepare the slide. It becomes convenient for everybody. Whatever is a visual impression and auditory impression are different. So visually, it remains in mind what is there. You have prepared well. I'm pretty happy that with your answers, but maybe next time it will be prudent to have the slides also. It becomes convenient. I think you have covered diagnosis, how it should be done. You have covered the clinical manifestations. We know that what complications can occur. And this is again one of the complications what you have brought out, that it can present with pretty high blood pressure, renal parenchyma hypertension. You have brought out this patient had diverticulosis, a diverticulitis. Even now, that's another complication. And lastly, somebody might ask you also about the Berry's aneurysm. Ravi did mention that almost 8% of the patients can have Berry's aneurysm. They can present with odd features of headache, or sometimes there's a rupture, subarachnoid hemorrhage, they can present. So if there is a family history of similar event, such people should be evaluated for Berry aneurysm, or somebody has got a job which is different. Like I say Air Force pilot or a pilot in the flight, that which is because there is risk to the life of so many passengers. It is something like same thing. A pilot getting gallstone, it is recommended that he should get it removed, not that he should keep waiting, because he is compromising the life of so many people. Likewise, if it's a pilot or one of those persons who can put the life of many people at stake, they have to be evaluated early. And if you find, now there are many modalities to do that. So one should keep in mind those complications also, which are there. And I think with that, if Ravi, if you say we can close the.
Yes, I think, sir, it was a healthy discussion. And I think I just want to say that always keep an open mind while taking history. And whatever positive history is, try to diagnose what is the cause. Whenever creatinine is high in front of you, first thing to come in mind is whether it can come down or it cannot come down. It is acute, chronic, or rapid. That's what I asked you. So whenever creatinine is high, you have to find out at that moment what was happening by asking more and more questions. Thank you, I think.
Thank you very much.
Bye-bye.
Thank you so much, faculty.
Thank you.
Thank you, sir.